Today I want to give you something that most medical content doesn't offer. Not only a list of symptoms, but a framework, a way of thinking about ear infection in children that will serve you each time this happens. I want to tell you first that most ear infections in children resolve on their own. Most of them do not need antibiotics, and most of them are not dangerous. But some of them can develop complications, and knowing the difference is important. Let me start with something that causes enormous frustration and confusion for parents. Let's suppose you take your child to the doctor. They are in pain, they've been up all night, and you are desperately looking for help. The doctor examines your child and he's saying, it's just an ear infection, you just need to wait. No antibiotics, maybe a paracetamol prescription. And you walk out of that appointment feeling dismissed, angry, maybe convinced the doctor got it wrong. I understand that feeling completely. Your child is hurting and doing nothing feels like failing them. And without an explanation, without understanding why waiting is sometimes the right answer, it genuinely feels discouraging. So before we talk about ear infections, I want to address this, because the watchful waiting is in fact one of the most important evidence-based decisions in all the pediatric medicine. But first, let me give you the framework that makes everything else understandable. To make this easy, we'll think of the ear as having three zones. The first zone is the outer ear, leading from the outside world to the eardrum. This is where the first type of infections are happening. Second zone is the middle ear, the small space sitting directly behind the eardrum. You can't see it from the outside. It connects to the back of the nose and the throat through a narrow channel called the eustachian tube. This is where otitis media is happening. The third zone is the mastoid, the bone you can feel just behind the ear. It's filled with air cells that connect it directly to the middle ear space. Under normal circumstances, you don't even think about it, but when things go wrong, can turn into an emergency. Now, why do children get so many more ear infections than adults? The answer is almost entirely related to anatomy. In adults, the eustachian tube runs at a 45-degree angle. It drains well. In children, it's shorter, horizontal, and floppier. It doesn't drain well at all. Think of the middle ear as a small room with one window, the eardrum, and one door, the eustachian tube. When your child gets a cold, that door swells shut, the room cannot drain, fluid accumulates, pressure builds, and the pressure is the pain that your child is feeling. That's an ear infection, the middle ear infection. And that anatomy explains why children grow out of ear infections with age, because the tube becomes wider, it's tilting, and it starts to drain, and then the ear infections will stop. Under the umbrella of ear infections, there are four types of condition. They look different and they need different response from your side. So let's talk about them one by one. First is the otitis externa, infection of the outer canal, the classic swimming pool infection. Here is how to recognize it. The pain gets significantly worse when you touch or press on the small cartilage flap at the entrance of the ear, that's called tragus. Press it gently. If your child reacts sharply, that's otitis externa. Treatment consists in antibiotic or antifungal ear drops prescribed by the doctor. Keep the ear as dry as possible and avoid putting anything into the ear, including earbuds, earphones, because while the infection is active, those can worsen the inflammation and the pain. Almost every parent believes that swimming causes an ear infection. And this is true for otitis externa, because the water sits in the ear canal and bacteria enter. But swimming has nothing to do with otitis media. Those come from viral or bacterial infections related to colds. The cold comes first, the ear infection follows. The temperature of the water, of the air outside, the wet hair on the way home from the swimming pool, none of that reaches the middle ear. Your child middle ear infections are not your fault for letting them swim. Otitis media is the classic middle ear infection. It's almost always following a cold. The child has a deep pain in the ear and fever. Touching the outside of the ear doesn't make it worse. The pain is behind the eardrum, not in the ear canal. Sometimes, and this moment can be frightening, the eardrum perforates. It bursts. Discharge appears in the ear canal. But something unexpected happens. The child stops crying almost immediately because the pressure is released. The eardrum has done exactly what it's designed to do under these circumstances. It has opened a drainage channel. The discharge looks alarming, but the child relief is real. Next, we'll talk about otitis media with effusion or glue ear. This one is different and is the one parents most commonly miss because it's not hurting. The glue ear means fluid is accumulated in the middle ear, which becomes thick and viscous, like a glue. There is no active infection, no pain, no fever, only hearing loss. A child with glue ear typically has 25 to 30 decibel conductive hearing loss. Consider what it means for the child. He is hearing the world the way you'd hear someone speaking to you from another room with the door half closed. They are not ignoring you. They are not being difficult. They genuinely cannot hear you. In the classroom, child looks inattentive, distracted. Teachers flag it. Parents worry about attention difficulties. Underneath all of it, actually, it's a child struggling to hear because of the fluid behind the eardrum that nobody has yet identified. Glue ear is the most common cause of acquired hearing loss in children. If your child has recurrent ear infections and you have concerns about their hearing, speech development, or behavior in school, ask your doctor specifically for a hearing test. Last, we'll talk mastoiditis. This is the complication parents fear the most. But the fear is sometimes disproportionate to the risk. I'll give you the numbers. Mastoiditis affects approximately 1 to 4 children per 100,000 children per year in countries like UK or Ireland. It is rare. The vast majority of ear infections never go anywhere near the mastoid. But it does happen, and when it happens, it's a genuine emergency. I want you to know how it looks like. The mastoid bone sits directly behind the ear. When infection spreads from the middle ear into the mastoid air cells, the area behind the ear becomes swollen, red, and tender. The ear itself gets displaced. It looks different from the other side, and the child is usually unwell with high fever and intense pain. If your child has an ear infection and you notice any swelling behind the ear, redness, or the ear being pushed forward, or your child becomes significantly unwell, do not wait for a pediatrician appointment or a GP appointment. You need to go immediately to the emergency department. Now, why do children get ear infections and why some of them get repeated again and again? The answer is a combination of immature immune system plus the short horizontal eustachian tube, which we described before. Viral upper respiratory tract infections are the trigger for the middle ear infections. Risk factors which are genuinely evidence for the middle ear infections are dummy use beyond 6 months of age, bottle feeding in a lying down position, passive smoke exposure, daycare attendance because it's increasing the viral exposure. Let me come back to the watchful waiting decision. The evidence on antibiotics for childhood ear infections is unambiguous. In children over 2 years old with straightforward, non-severe, one-sided ear infection, antibiotics reduce symptom duration by only 1 day. In exchange for that 1 day, the child gets severe side effects, diarrhea, rashes, and a small but real contribution to the much larger problem of antibiotic resistance. The number of children who would need to be treated with antibiotics to prevent a single case of mastoiditis is estimated in thousands. So the doctors are protecting the children with the full weight of the evidence behind that decision. Here is the clearest version I can give you of what to do and when. A child over 2 years old with moderate otitis media, generally well, needs only analgesia and watchful waiting up to 72 hours. A child below 2 years with bilateral otitis media or perforated eardrum needs to be evaluated in the same day. Otitis externa needs antibiotic ear drops or antifungal ear drops prescribed by the doctor. If a case of glue ear is suspected, then first thing is to get a referral for a hearing test. If the glue ear is persisting more than 3 months, then ENT referral is required and potentially grommets discussed. A post-auricular swelling with an ear pushed forward and the child is systemically unwell needs immediate evaluation in the emergency department. Pain relief is required in all these cases. Few questions worth having ready for your next doctor's appointment. Does my child need a hearing test? At what point should I come back if it's not improving? Can this be a glue ear? What is the opportunity to discuss about grommets? Having these questions prepared will help you understand better your child's condition. Ear infections cover a spectrum from something that will resolve with paracetamol and patience to a genuine emergency that needs immediate attention. The skill isn't knowing every detail of the medical management, it's knowing where your child sits on that spectrum and when to trust the process and when to move fast. In the end, I invite you to download the free Parents Red Flag card. You'll find it in the description below, which is telling you when to wait, when to call, when to go to emergency. The full written guide is on the website entforeveryone.com with a management ladder, 4 conditions, and the questions to bring to your next appointment. If this video helped you understand something that you've been confused about, please leave a comment below. Tell me what you wish you'd known earlier. Understanding is genuinely part of the treatment. Thank you for watching. See you next time.